Hello, my name is Joe Rimkus, and I'm going to be presenting managing intracranial pressure with 3% hypertonic saline versus mannitol. Here we go. Let's first start with some basics, and we're going to talk about the Monroe-Kelly doctrine. Now, what's the Monroe-Kelly doctrine state? Remember, our brain is inside a hard, closed skull to protect it. And the Monroe-Kelly doctrine states that the sum of volumes of brain, CSF, cerebrospinal fluid, and intracranial blood is constant. There's 80% brain tissue, 10% cerebrospinal fluid, 10% blood. Any increase in the volume of any of those components necessitates a decrease of the other through compensatory mechanisms, an increase in intracranial pressure, or both. Remember, the brain box is a fixed structure. It provides that support and that protection for the brain. So inside that brain, that skull, something must give. If one goes up, the other one must go down. Right, so some other basics. Normal pressures in our brain box, I like to call it, the skull. So intracranial pressure, our normal range is between 7 and 15 millimeters of mercury. Cerebral perfusion pressure, normal range is between 60 to 80 millimeters of mercury. So how do we calculate our CPP? You take the map and you subtract your intracranial pressure. So an easy way to remember basically is anything over 20 millimeters of Hg of mercury is a problem in any compartment in the body. But today we're talking about intracranial pressure. So if we're over 20, we're compromising blood flow to the brain. So we must do something to temporize and assist maintaining the CPP in the presence of an increased intracranial pressure. So how can we do this? Well, some basic things that we can do in our pre-hospital care or care of anybody with TBI or potential brain injury. First, we can raise the head of the bed, which assists in drainage by gravity, helps reduce pressure on the head. Secondly, we can administer sedation and medication for analgesia to reduce the pain response. It helps reduce intracranial pressure. We can also provide medicines such as Keppra for anti-seizure prophylaxis to increase the seizure threshold. Remember, any seizure activity is going to cause increased intracranial pressure. If the patient happens to be vented, we can bring down their EtCO2, their end tidal, to 30 to 35. That will help somewhat decrease intracranial pressure. We want to avoid suctioning unless absolutely necessary. We want to treat fever, minimize shivering. Remember, if the body gets cold, especially in traumatic situations, one of the things we always forget is to keep them warm. If they're shivering, we're causing increased intracranial pressure. Avoid hypotension. Maintain SBP greater than 90. And that actually should say MAP. The MAP should be greater than 90. And the reason we do that is because if you figure that our ICP is greater than 20 in a brain injury case, if we maintain our MAP pressure of greater than 90 and you subtract 20, that's a CPP of 70, and we want to stay between 60 and 80. Also avoid hypoxemia. Maintain SpO2 greater than 90%. Now focusing more on what this presentation is about. There are two medications or agents that we can use to reduce swelling in the brain. 3% hypertonic saline, which we'll further call HTS in the rest of this presentation, and also mannitol. Remember, our job is to prevent that secondary brain injury. We can't stop the primary brain injury, that coup contra coup, or where the brain structure hit the skull inside and where it might be bleeding. We can't control those primary things, but we can control secondary brain injury. And the biggest one is the swelling that comes from that primary brain injury, from either bleeding or damage, etc. Next, we're going to talk about 3% saline. And I know for a while I didn't understand what 3%, 0.9 normal saline actually meant. I just knew there were numbers and I knew they were different. So some basics on what 0.9 normal saline is versus 3% saline or hypertonic solution. 0.9 normal saline is 0.9 grams of salt per 100 cc's of water, while 3% saline or hypertonic is 3 grams of salt per 100 cc's of water. So you can see that there's a big difference between a 0.9 and a 3%, but now you know why, because the amount of salt per 100 cc's per water. So with that, you got to remember that there are more solutes in 100%, there are more solutes in 100 cc's of 3% saline than 100 mils of 0.9 normal saline. So it makes that fluid more concentrated. That works with osmolarity. So let's talk about osmolarity. The osmolarity of our normal serum, our blood serum, is 275 to 295 milliosmoles per liter. Osmolarity of 0.9 normal saline, 308. And then osmolarity of 3% hypertonic is 1027. So you can see such a huge difference. And what that means is there are more solutes within that fluid than there are solutes within the fluid of the serum. It's almost, 3 times? So because of that osmolarity difference, that's what causes that fluid shift from the cells into the intravascular system. 3% saline is given intravenously. It places a fluid of higher solutes in the intravascular system compared to that of the cells. It should be given via a central line, but in emergency situations, we can give it peripherally. We just have to worry about extravasation. And this will cause the water, like I said, to move from the cells into the intravascular system, thus with respective shrinkage of the cells, which will help reduce brain swelling. So hypertonic solution leads to a shrinkage of normal brain to allow for the edematous brain to have more space, thus lowering ICP. It's an easy way for us to control that intracranial pressure without having to open up the skull, which is what might have to happen in neurosurgery. Hypertonic solution also leads to a shrinkage of red blood cells and allows the ability to pass easier through tighter capillaries. So as that brain swells, those capillaries get smaller because of the increased swelling in the brain. It will actually help those blood cells flow through there easier. Hypertonic solution is excreted via the kidney. 3% saline does not induce as much diuresis as mannitol. We'll talk about that in a second. It can increase intravascular volume as it draws fluid into the intravascular system. And why that's important to remember is patients that are in multi-system trauma that need to be resuscitated with fluids, this can be an easy way to help bring fluid into the intravascular system if we're worried about them being hypovolemic. It also induces the release of vasopressin, which leads to free water retention. Now, according to the study of optimal dose and concentration of hypertonic saline in traumatic brain injury, it was a systematic review done in June of 2022, the therapeutic dose is 1.4 to 2.5 milliliters per kilogram given as a bolus. All right, let's talk about mannitol, the other agent we can use to reduce intracranial pressure. Mannitol is composed of a sugar and an alcohol that is not metabolized. It's an osmotic diuretic, so it does cause diuresis. It remains in the extracellular space and draws out water from the cells by the osmolar gradient it creates. Mannitol shrinks the normal brain tissue to allow the edematous brain to have more space, thus decreasing ICP. So it does the same thing as 3%, it just does it in a different way. It's excreted via the kidney, and remember, again, it induces diuresis. Now, mannitol shows to decrease intracranial pressure after about 1 to 5 minutes, and it peaks at about 30 to 60 minutes. Some of the complications include dehydration and hypovolemia and acute kidney injury. And again, the thing to remember about mannitol is because it causes diuresis, if a patient is hypovolemic already and we're given mannitol, we're potentially causing an issue that we're going to have to chase. Biggest thing with mannitol is you have to use a filter. It will crystallize. You might not see the crystals in the bottle or the jar that you're delivering it with, but you will see there will be crystals, so you have to use a filter. Dosing according to optimal dose of concentration of hypertonic saline in traumatic brain injury. it's the same review that we talked about in the last slide, is 0.25 grams per kilogram to 1 gram per kilogram bolus, and it can be repeated every 2 to 6 hours. The dilemma comes: which one do we choose? Which one should we use? There's a handful of studies that have been out there, but I'll show you here in a few slides that there's not enough data out there to say one versus the other. So I'm just going to give you a couple studies just so you can kind of see some of the information. But in this study of hypertonic saline and mannitol in patients with traumatic brain injury, it was a systematic review done in 2020. There were 544 patients enrolled, 270 with hypertonic, 274 with mannitol, and they found that there was no significant difference in the decrease of ICP and the onset of drug between the two groups, meaning they both worked just as equally. But they did find there was a statistically significant difference in the terms of duration effect. 3% showed a more sustained effect on ICP, thus increasing cerebral perfusion pressure. So there's a little bit of information or a little bit of data in there that says that 3% might be better than mannitol because of their duration, but they both reduce intracranial pressure. In another study, it was a systematic review comparing hypertonic sodium solutions and mannitol for a TBI. 191 patients in that study, and they found no difference between hypertonic solution and mannitol for reducing ICP. That was done in 2016. Another study in 2019, hypertonic saline versus other intracranial pressure lowering agents for people with acute TBI. 295 patients in that study, and it really just came to the conclusion that weak evidence to suggest that hypertonic is no better than mannitol in efficacy and safety in the long-term management of acute TBI. So where are we at then? Well, there is limited data from studies currently that suggest one agent over the other. More information has to be drawn, more data has to be taken from studies, more studies need to be conducted. So what do we do? We know that both hypertonic and mannitol are effective at reducing ICP. We know why they actually reduce the ICP. A swelling brain increasing ICP is a neurological emergency. We have to treat to reduce secondary brain injury. Hypertonic solution can be effective as a volume expander for those in multi-system trauma needing resuscitation. So a big consideration is, again, if they're hypovolemic, if they need blood, if they're already, we're trying to chase a map and try to get their map up so that we can compensate for that increased intracranial pressure. Hypertonic might be a better solution for patients in those situations. Also remember that mannitol is a diuretic, which can cause secondary hypovolemia. So again, we might be chasing low blood pressures. So you have to just really consider the situation. So really what it comes down to is whatever agent that is readily available should be administered. This is a neurological emergency. We can prevent secondary brain injury and herniation. How do we do that? Well, what agents do we have available? And really it's, to follow your protocols and the direction of your sending and receiving physicians. So if we want to change practice, it's going to be one of those things where we have to do studies. We have to do more research and find out which one is better than the other. But right now, there's nothing saying one is better than the other. So that's it. I appreciate your time today. I hope that you have a little better understanding of hypertonic versus mannitol. And thank you very much.